Good afternoon. Good afternoon, everyone, and let me add my welcome to all of you. It is my great pleasure to introduce our new Voices in Clinical and Translational Science series sponsored by the Integrated Translational Health Research Institute of Virginia, or iTHRIV. As you recall, the mission of iTHRIV is to catalyze and sustain inclusive clinical and translational research through diverse, collaborative team science, innovative data science, and broad workforce development in order to improve human health and promote health equity. This new series serves as a platform to lift outstanding researchers and underrepresented voices in research across the iTHRIV partnership, with a focus on promoting dialogue and encouraging team science. The series is aimed at amplifying diverse perspectives in clinical and translational research to foster innovative and an inclusive environment. We will be highlighting some of our amazing iTHRIV researchers who will share their research and their lived experience with us. So it is my great pleasure to welcome today's speaker, Dr. Sula Mazimba. Dr. Mazimba is an associate professor of medicine in the Advanced Heart Failure and Transplant Cardiology Division of the School of Medicine at the University of Virginia. He received his medical degree from the University of Zambia and completed his internal medicine residency and cardiology fellowship training at the Kettering Medical Center. He then completed his advanced heart failure, heart transplant, and pulmonary vascular disease fellowships at the University of Alabama at Birmingham before coming to UVA in 2014. Additionally, he has a master's degree in public health and global health and health management from Wright State. He is currently the director of the cardiogenic shock program at UVA and the co-director of the pulmonary hypertension program. He is an active clinical investigator, and his research focuses on understanding and providing treatment options for patients with advanced heart failure. Today, Dr. Mazimba will talk to us about racial and ethnic disparities in heart failure, the state of the road toward equitable care. It is an absolute joy to have Dr. Mazimba as our inaugural speaker for this series. He is known by his local and national colleagues as an outstanding clinician and researcher. He is a prolific writer with over 80 peer-reviewed publications, including many in the last 2 years, that in particular address innovations in cardiac care and that address health inequities in cardiovascular disease. His demonstration of leadership, innovation, research rigor, team science, and inclusivity are models for us all. Please join me in welcoming Dr. Mazimba.
Thank you, Karen, for those kind words. Greatly appreciate. And I'm also very thankful to be the inaugural speaker for this wonderful platform to be able to raise the voices of clinical researchers. My talk today is on racial and ethnic disparities in heart failure. And we'll look at really the road ahead of us in terms of equitable care. I have no conflicts to declare. The objectives of the talk today will be discuss the social construct of race and cardiovascular disease. We'll also review the racial ethnic disparities in heart failure, and then also discuss key determinants of disparities in heart failure. We'll then explore some strategies for addressing disparities in heart failure. Now, race is not a biological or physiological construct. Instead, it's actually a social construct, and it's based on a selected combination of arbitrary physical characteristics, continental ancestry, and ethnic identity. And ethnicity, on the other hand, refers to group identity based on shared culture, language, and or beliefs. The genome research has showed that humans are actually 99.9% similar, and that the 0.1% dissimilarity that we have on the genome is actually, accounts for a lot of the neutral genes, as a matter of fact. So most of the genetic makeup or phenotype that that we see is actually mostly shared in the 99.99%. However, given the fact that we have about 6 billion bases of DNA, a 0.1% difference represents about 6 million locations that differ between two individuals, for example. But most of those, like I said, are very neutral. They do not impact genetic or phenotypic expression in a lot of those cases. So what are health disparities, and what's the difference between health disparities and versus healthcare disparities? There is expected variation in health conditions. For example, it would be unusual to see a teenager have a heart attack. But when a 70-year-old patient has a heart attack, that can be explained by the sheer reasons of just age and vascular aging, as it were. But health inequities, on the other hand, are systemic differences in health status between different socioeconomic groups. These inequalities are socially produced, and therefore they are modifiable and unfair. The Institute of Medicine defines a disparity as a difference in treatment provided to members of different racial or ethnic groups that is not justified by the underlying health condition or treatment preferences of a patient. So equity in health implies that ideally everyone should have a fair opportunity to be able to attain their full health potential, and that none should be disadvantaged from achieving this potential. So health disparities, just to define the term, really refers to a higher burden of illness or injury or disability or mortality even as experienced by one population group relative to another. A healthcare disparity, on the other hand, refers to differences in the population groups in terms of care received or health coverage or access to care. So since we are talking about heart failure, what is heart failure, and what is the scope of the problem? So heart failure is not necessarily a single pathological diagnosis. It is a syndrome, and it's characterized by structural or functional abnormality of the heart, and in the process leading to limitations and excess mortality. So the mortality after diagnosis at 1 year is approximately 20% and 53% at 5 years. So in general, we define heart failure based on the function of the heart. So some of the terms that we'll talk about in this talk, for example, heart failure with reduced ejection fraction. This is where the left ventricular ejection fraction is less than 40%. And if the ejection fraction is more than 50% and patients have heart failure, then they are categorized as heart failure with preserved ejection fraction. And then there's this middle range of ejection fraction of 41 to 49%, which is referred to as heart failure with mid-range ejection fraction. So heart failure in the US is a big problem. About 6.2 million Americans greater than 20 years of age have heart failure, and the prevalence is expected to increase by about 46% by the year 2030. So we should expect that it's projected that over 8 million people will have heart failure over the age of 18 by 2030. The total percentage of the population with heart failure is projected to rise from about 2.4% in 2012 to about 3% in 2030. And that will mean that the healthcare burden in terms of total cost of care will rise up to about $70 billion a year. Currently, it's estimated to be about $30 billion a year in terms of total cost. Now, when you look at the population attributable risk factors, you can see here that coronary artery disease is the number one in the general population, followed by cigarette smoking, hypertension, low physical activity, male gender, and then there, of course, the social determinants of health, such as high school education and so forth. Now, this is just in the general population, but when you look closely at the risk factors in the ethnic minorities, hypertension tends to take the predominant risk factor that's attributable to heart failure. So some of the risk factors include, just like I mentioned, hypertension, diabetes. But when you look at the total burden of symptoms in terms of heart failure prevalence, you find that African American patients tend to have the most disproportionate burden of heart failure prevalence. For example, in the MESA study, which is a multi-ethnic study of atherosclerosis, which is a longitudinal study that has been following patients over time, the prevalence of heart failure was higher in African Americans, followed by Hispanic, and then white patients and Chinese Americans, with incidence of about 4.6 in the African American and 3.5 in the Hispanic population, with whites having about 1.0 per 1,000 person years incidence. Again, higher risk is reflected by hypertension, diabetes, and low socioeconomic status. Black individuals also had the highest proportion of incident heart failure that was not preceded by coronary artery disease. When you look at the more recent studies, you find that even in the younger age group, for example, in this cardiac study, which is another, like MESA, which is another cohort, prospective cohort that has been following patients prospectively, you find that the burden of heart failure, even in younger patients who have relatively fewer to no risk factors, is quite high amongst African Americans. There was a 20-fold higher incidence of heart failure in young Black women and men under the age of 50 years compared to white men and women. Again, you see that as you can see here in the cumulative hazard of heart failure, you can see African Americans and followed by Hispanic and white, and then of course the Chinese patient cohorts. So racial disparities in cardiovascular death also abound. Death rates for heart disease have decreased in general, but in the trajectory over the last few years has slightly been up on the upswing, and the death rate still is quite high amongst African Americans, followed by white patients, and then Hispanics, and lastly the Asian or Pacific Islanders. Again, you find racial disparities in heart failure mortality. Specifically, you find that there is premature mortality in young and middle-aged African American patients. If you see the graph, the age 35 to 64, the prevalence of mortality was quite high amongst African American young patients, and which also continues into the later age, 65 and 84 years of age group. You find that African Americans still predominate in terms of mortality. when you look at heart failure hospitalizations, you find that there are still, even in this setting, significant disparities. In this study that looked at a national sample of inpatients, the admission of heart failure patients was really characterized by a number of disparities. For example, you found that among elderly heart failure patients who were presenting to the ED, white patients were more likely to be admitted than Black patients. Even when you control for the disease, for the acuity of the disease of heart failure, as you can see here, the acuity of patients was higher, and yet the number of patients that were admitted into the hospital was quite low for the African American cohort. This is one of the studies that we looked at using the Premier database. We found out that out of over 100,000 patients who were admitted to the hospital, 80% of those patients were white, and about 20% were African Americans. But when you looked at the referral to a cardiologist, it was much lower by African Americans. And we know that being seen by a cardiologist is associated with better outcomes. And so we found in this cohort, patients who were not seen by a cardiologist, despite being in the ICU, had had higher, of course, mortality and readmissions. So the higher likelihood of survival was not affected by race in terms of if patients were seen by a cardiologist. So again, here you see that there was significant disparities in terms of receipt of care by a cardiologist among patients who were admitted in the ICU. Again, with respect to Hispanics versus whites, Hispanic patients have a higher cardiometabolic risk profile. They tend to have higher risk factors such as obesity, hypertension compared to white. We also find that Hispanic patients with heart failure with preserved ejection fraction were more likely to have non-ischemic etiology as opposed to whites. And heart failure with reduced ejection fraction amongst Hispanics tended to be mostly driven by ischemic causes. So Hispanic patients have, with heart failure with preserved ejection fraction, have lower mortality compared to white. But with respect to heart failure with reduced ejection fraction, they have similar mortality to white patients. So racial disparities in heart failure hospitalizations, as you could see here, have prognostic implications. Anytime you are admitted to the hospital, the risk of mortality increases. And so when you have 2 or more heart failure hospitalizations within a year, the risk of mortality increases by about 30%. And heart failure hospitalizations since 2014, as I mentioned, have been on the rise and predominantly affecting African-American young men and women. When it comes to identification of racial disparities with respect to admission to the hospital, we showed that being in the ICU did not guarantee that you'd be able to be seen by a cardiologist in general. There were disparities there. But how about just admission to a general cardiology floor versus a general medicine service versus a cardiology floor? Here, the Brigham group, some of the colleagues we are working with, reviewed reviewed about 2,900 patients who were admitted at the hospital. And in this retrospective study, they showed that the number of patients who were admitted to a cardiology service were much lower if they were African Americans or Latino patients. And so this also led to increased readmissions to the hospital. We have done similar data, which is still currently under review. Preliminarily, we have also found similar sort of patterns, and we will be looking at that data, our data closely as we move forward with our collaboration with our Brigham colleagues. But it suffices to say that the data tracks very well with what they found. So when we look at the racial disparities in guideline-directed medical therapy, again, must say that one of the important advancements that have occurred over the years has been the efficacious guideline-directed medical therapy for patients with heart failure with reduced ejection fraction. And this has been a major advancement in the field that has really improved outcomes overall. But when you look at the adherence to guideline-directed medical therapy amongst patients with heart failure, it's quite low. I mean, you find that in the CHAMP registry, patients who are eligible for guideline-directed medical therapy, about 2/3 of the patients, in many cases, were not given guideline-directed medical therapy, which is really sad because we do have these medications that can change the trajectory of heart failure. In fact, over about 300,000 heart failure deaths could be prevented with just adherence to guideline-directed medical therapy. And we find that Hispanic ethnicity is less likely to be treated with angiotensin receptor neprilysin inhibitors, which are quite effective therapies for heart failure. And they are also less likely to receive beta blockers or mineralocorticoid antagonists. A study by Vaduganathan, which was published in Lancet in 2020, demonstrates, for example, how just being adherent to the 4 foundational heart failure medications, the ANI therapy, beta blocker, mineralocorticoid antagonist, and S inhibitor or SGLT2 inhibitors, you can add about 8.3 years to conventional therapy. So being on the 4 medications could actually increase could add about 8 years of life beyond just conventional therapy. So and that's quite effective in terms of adhering to guideline-directed medical therapy. And yet we find that there's still quite underutilization of these guideline therapies. Now, this is all across the board, but much more so in the ethnic minorities. So, as I mentioned, despite the benefit of combination therapy, the 4 guideline-directed medical therapy, there's still quite a lot of underutilization. And more specifically for African Americans, there's one class of medication, the isosobide hydrazine and the isosobide nitrate combination, which also has been shown to have increased and morbidity benefit. Although historically African Americans and Hispanic patients have less likely been able to get these device-based therapies, the gap is narrowing for the ICDs, but CRT still remains quite disparate. There's still some disparities in CRT receipt between the ethnic minorities and and white population. How about heart transplantation? Heart transplantation is effective durable therapy for heart failure. But when you look at the proportion of African American on the wait list, it has decreased over the last decade. And you also find that the significant disparities with respect to African Americans and Hispanic patients with regards to wait times, and as well as increased death rates on the wait list. So we still have a lot of underrepresentation in heart failure clinical trials. While white patients make up 67% of the US population, they are about 83% represented in research. However, African Americans about only 5% with the representation of about 13% of the total US population. And then with Hispanic, Latino, you have about 18% of the US population, but less than 1% of less than 1% of clinical trial participation. So there is increased need, as you'd expect, in dismantling these disparities in terms of clinical trial representation. And we know that clinical trials do provide important information regarding therapies, especially in population subgroups. Minority groups are underrepresented in clinical trial enrollment, and some of this could be due to just historical legacies of injustices in clinical trials. Some of it could be just local principal investigator inertia to enroll patients who are underrepresented. And in one of the, looking at some of the heart failure clinical trials, for example, there are about, out of the 25 notable randomized clinical trials, only about 48% of African Americans were represented in these clinical trials. So you can really see that there is significant disparities in terms of representation. And many of these clinical trials rely on real-world data, and so you find that there's disparate findings in many of these cases because of underrepresentation in the clinical trials between real-world data and the clinical trial data. So coming back to genes, environment, and the interaction of the genes and environment and heart failure, Dr. Francis Collins once said that genes load the gun and the environment pulls the trigger. The social determinants of health are particularly very important in terms of influencing the trajectory of disease manifestation in heart failure, not only in heart failure, but even in other clinical conditions. So here we see that the genes will lead to susceptibility of a clinical phenotype, but it's the manifestation of the manifestation of the social determinants of health that actually impact the manifestation of particular disease condition.
Okay. And
so social determinants of health are the conditions in the environment where people are born, live, learn, work, or play, or worship, and may affect a wide range of health functioning and quality of life outcomes.
She did say if it does not, then she thinks it will. She said,
I think one of the mic is not muted.
Yeah, Jeanette Gonzalez. Jeanette, could you mute, please? We're sorry, but could you mute, please? Thank you.
yes, sorry about that.
Thank you. So with the social determinants of health, they impact the trajectory of the disease condition. So just having a susceptibility to a gene for a particular disease condition does not necessarily guarantee that you have that disease. But it's your exposure to the environment that actually leads to the manifestation of the disease. And so in many situations, the environment where individuals live shape the trajectory of how the trajectory of heart failure, the burden of heart failure, and this also applies to many other disease conditions. And when you take into consideration the fact that there is indeed higher prevalence of modifiable risk factors in African Americans, with about 70% of risk factors that could be modifiable, such as obesity, hypertension, and other conditions that could be modified. And so the conditions, the social conditions in which patients live in determine how they manifest the disease and even prognosis and trajectory of the disease. The Institute of Medicine published a seminal publication regarding disparities in 2002. And in their report, they did make 3 cardinal findings. One was that racial and ethnic disparities in healthcare exist, and because they are associated with worse outcomes in many cases, they are unacceptable. They also made a report that racial and ethnic disparities in healthcare occur in the context of broader historic and contemporary social and economic inequalities, and that there is evidence that there is persistent racial and ethnic discrimination in many sectors of American life. And they did note that there are many sources of these disparities, including health systems, healthcare providers, patients, utilization managers, may all contribute to racial and ethnic disparities in healthcare. They also mentioned in the report that bias, stereotyping, prejudice, and clinical uncertainty by healthcare providers do contribute immensely to racial and ethnic disparities. A small number of studies do suggest that racial and ethnic minorities patients may more likely than white patients to refuse treatment, but the refusal in general does not account for the vast disparities that are observable and prevalent, so widely prevalent. Last year or 2 years ago, the American Heart Association did make a presidential advisory, really categorizing the disparities, particularly amongst African Americans, and really putting into context the historical and the historical legacy of structural racism. So, as you can tell from this figure here, with slavery and structural racism to maintain white supremacy policies, such as Jim Crow laws and segregation and redlining, really that affected Black people in the US, created conditions to which we now have, where we have poor housing, social conditions, sometimes poorly funded schools, poor access to healthcare, and toxic stress, which we'll talk about, as well as just ambient racism that increases the burden of cardiovascular disease and influencing wide prevalence of stroke and heart failure. So race is a proxy for unique stressors that affect minorities, and Blacks are more likely to experience chronic stress in situations such as material hardships, structural discrimination, mentioned ambient stressors, and segregated housing. there is the weathering hypothesis that was proposed several years ago that explains the premature decline of health that is observed in African Americans, particularly African American female patients. And this has been validated and replicated in multiple studies. In the Cardia study, which is a prospective study looking at development of cardiovascular disease conditions with time, in this cohort of about 2,600 participants, Blacks had been noted to have a biological age that was 2.6 standard deviation, which is roughly about 12 years older than their chronological age, as opposed to whites who were about 3.5 standard deviations younger, really accounting to about 10 years younger than their chronological age. And this weathering concept really denotes the body's ability to sort of withstand the wear and tear, as it were. So when they looked at the separate cohorts, you could really see how disparate the biological age versus chronological age were between the two racial groups. There's been a lot of studies that have also looked at the impact of systemic racism, or even just on ethnic minorities. In this one study, they noted that compared with those who reported never thinking about their race, the odds of obesity were high, versus those who were exposed to environment that where they were confronted with race stressors. So internalized impact of racism through experiencing high levels of race-related vigilance may be one of the risk factors that places African Americans at increased risk of obesity, and not only obesity, but even other risk factors such as hypertension and diabetes. So what are the foundations of equity in heart failure care? So health equity can be improved, but it has to be multidimensional, multidisciplinary, because there are more than just one aspect of pathogenesis that leads to the development of these disparities. So we know that having a community, being in a community where people are able to go to to work in an environment where they can get income, does make meaningful contribution to their livelihood, will lead to good health outcomes. And so the multidisciplinary nature of equity has to be addressed at multiple levels. For example, optimizing access to healthcare. In many cases, ethnic minorities do not have access to insurance, for example. They may not have, even when they do have access to insurance, they may be exposed to bias in terms of diagnosis and even triage of care in the hospital. And so having bias training, removing barriers to heart failure referral, for example, as we've noted, that many patients, when they go into the hospital, do not necessarily have access to specialty care, for example. So it requires multidisciplinary intervention. The social determinants of health, 5 domains, and those domains include healthcare access and quality, economic stability, social and community context, educational access and quality, and neighborhoods and built environment. And so if we're going to make any meaningful improvement, it will be really being able to have a multi-disciplinary approach with allyships in terms of being able to confront healthcare disparities. There is an African proverb that says, if you want to go fast, you go alone, but if you want to go further, you go together. And so this is where multidisciplinary involvement is extremely important in terms of being able to prevent and dismantle these disparities that we see in heart failure, not only in heart failure, but in other conditions. Thank you for your attention and listening. And at this point, I would stop to see whether there are any questions.
Thank you so much, Sula. That was really great. We will take a moment to invite questions from the audience.
I have a question, Dr. Francis. Does the doctor feel that enough is being done at institutions to protect the African Americans or the Black Americans from these, the same things that they face in the community? We end up facing the same thing inside the hospital, we're finding. So how robust should these institutions be to make sure that the hospitals are safe places for Black people to come?
I think one of that's a good question. One thing is a lot of clinicians or people working in the hospital, they go into medicine or in clinical care because usually with altruistic ambitions, and many times it's not that people are necessarily racist, but it's just that there's implicit bias, which may be reflected in terms of just perceptions of perhaps pain tolerance and so forth. That can be education, and that's where education comes in, for example, and being able to have training that that spans across specialties in terms of competence, in terms of being able to take care of patients who are outside the ethnic representation. And so those are some of the areas that are really important. And I think that many of the times it's not that people are really inherently just outrightly not necessarily or bad. It's just that they are just these implicit bias.
Are you satisfied that this is being done on the level of medical students? Because you have to, you mentioned the role of hypertension and heart failure, but also the training of our medical students. They get to be doctors eventually. Are we training them at this level for this kind of social impact that they could have years down the road?
Yeah, Well, I think that's a very good question. Again, one of the things that what has been reported again in the past has been that sometimes the training at the level of medical students is key. Many of the times medical students are given the opportunity to see patients in underserved clinics, and sometimes in those areas, those are sometimes in areas where they pick up biases because of just because they are exposed mostly to indigent care, and but I think that this is an ongoing process. I think that more and more discussions are going on about the role of implicit bias in care and how it affects outcomes. Such platforms like the one we are having today are platforms where exchange information about just these disparities, and many people don't know about these disparities that they occur. I see there's a comment in the chat that the use of the term African American is misleading, and that the group that we are speaking of are Black Americans who are descendants of slaves brought to this country in 1619. Can you comment to that, Dr. Francis? What you mean?
Yeah. I think people use the term African American has sort of been we don't really know what to call ourselves at one point, but I think the people who are being discriminated are the people who are descendants of slaves. And this is like, we're caught up in Jim Crow and everything like that. And this is, over the years, we've ended up with less money, less housing, and living in certain zip codes. And we have to admit that. I mean, I don't think these are people from the Caribbeans or people from Africa necessarily. I mean, once you get to America, you get grouped into this, but these are the people that we're talking about.
Yeah, I would beg to disagree there because we've seen the data in terms of these national data sets. When you look at the totality of the evidence, it's that they don't usually ask that are you from the Caribbean. The categorization as it is currently is either Black or African American, and so the data that we have with respect to outcomes, adverse outcomes that and disparities in healthcare are really Black Americans in essence. But you're right, the terminology of Black Americans and African Americans is certainly contentious. And in terms of being all inclusive, there are certain demographics or certain sometimes differences in disease propensity between African and Caribbeans and African Americans. And this may be reflected by the stress levels and perhaps socioeconomic conditions that prevail in these separate demographics. But when you look at the data that we're presenting in terms of published data, it does not really categorize these groups as whether it is African American from Africa versus Caribbean.
Thank you.
Karen.
Actually, I'll yield to Tracy. Tracy, you want to ask your question first and then I'll ask mine?
Sure. Thanks, Karen. Sula, great talk. If you were to design a heart failure dashboard to help a health system keep track of these differences in outcomes, are there certain parameters that you would think we should measure here at UVA and at other health centers?
Yeah, that's a very good question. I think some of the key areas where we find disparities are actually in procedural-based areas. we find that African Americans are less likely to get, for example, device-based therapies like CRTs, less likely to get cardiology appointment, for example. In general, our own data, we're yet to see what our own data shows, but we're actively looking at that in terms of seeing the admission to cardiology service versus general medicine service. But it tends to be that in many of the cases where you find clinicians high, where the high-end sort of procedural-based care, that's where you see a lot of disparities. Cath, for example, in general, I'm not talking about our institution, but when you look at published data, when it comes to cardiac catheterization, you find gross disparities there in terms of access to specialty services such as cath lab. So I would certainly look at for cardiology, for example, device-based therapies. I would look at access to cardiology services. I would look at access to guideline-directed medical therapy, because only about 10% of patients are actually on guideline-directed medical therapy that were eligible for guideline-directed medical therapy. So in those cases, I think that dashboard would be very instructive in being able to show exactly how the trajectory of care across the spectrum across the spectrum of care in the institution.
Yeah, my question was similar, Sula. I was really struck by the data, the emergency department data, in terms of who gets admitted to the ICU, who sees a cardiologist, who gets sent home, those things. And I was thinking along the same lines as Dr. Downs, and I love Dr. Downs's approach of thinking about dashboard data. What do you see as kind of an actionable item on the front lines in the emergency department that we can start thinking about, not just for cardiology, because we see this in stroke as well, right? So what do we do in the emergency department to help people understand that they are behaving differently with different populations and that is not best care?
Yeah, that's really a very good question. One of the things that can be done, clinical decision support tools, where when a patient, we can do this. If a patient comes in self-identified as African American or Black American, comes into the hospital, we know that there is implicit bias in terms of allocation of resources. They need to be prompting by clinicians to say, have you considered this guideline-directed therapy for this particular patient? I think we have the tools in EPIC and in medical record to be able to have such such a platform to be able to sort of triage patients at that level. It might even go to include device-based therapies. There are patients who have had a low ejection fraction for years, and yet they do not have, they've not been offered an ICD, for example. And so the electronic medical record can put up an alert to say, have you considered, an ICD? And someone needs to, either, make a justification as to why, or make a referral at that point.
Hello, I just wanted to say this is a great conversation, and I'm happy that it's actually coming to the forefront. What I am sad about is looking at the population of who's attending. It just got, I'm like, this is awareness that needs to be shared a little bit more. And like, how do you do this? You have, in my opinion, you're going to have more of these conversations, and you're going to have to bring this to light that much more. UVA as a whole has a responsibility of making sure they pay attention to the implicit biases that's taking place, and that's happening along for our clients and also for our staff. Just want to make that clear. I mean, I can give a personal piece where not UVA, but I went to a doctor's appointment, first time with a doctor one time, and they were just seeing me. And because I was heavy and I was dark, something had to be wrong with me. And they were doing everything they could to see what was wrong. And finally, she had to say, I'm sorry. So the point is that don't make an assumption about who you see, and that you have to allow room and space to have more of these conversations. And the only way you're going to bring awareness is not giving up on these conversations. And when you see them, to address them up front. Thank you. But continue these conversations. I want to be on the next one when you have it.
Thank you. Thank you so much. Thank you. Good point.
That's a beautiful way for us to end. Thank you for inspiring us. And Sula, thank you so much for sharing your perspective today and for bringing this word to us. It's really motivating, right? I think for all of us. So really want to appreciate everyone taking time to be with us today. And we will look forward to seeing you again in June for the next of our presentations in this Voices series. Thanks again.
Thank you. Thank you for the opportunity.